Hello and welcome to the CME activity entitled The Immunology of Obstructive Lung Disease and the Emergence of Biologic. My name is Nick Hanania. I'm professor of medicine and director of the Airway Clinical Research Center at Baylor College of Medicine in the section of the Pulmonary and Critical Care in Houston, Texas. It's my pleasure to be moderating this session today. Our learning objectives include recognizing the underlying immunology associated with certain obstructive lung disease, evaluate recent trial results for the use of biologics to treat obstructive lung diseases, and considering the implication for clinical practice. And thirdly, assess the barriers that have limited the use of biologic therapy to treat obstructive lung diseases and identify some strategies to potentially overcome these. We will have several sections in this module. One is we're going to discuss lung immunology of obstructive lung diseases, particularly asthma and COPD. We will dive into biologic targets for asthma and COPD. We will discuss optimizing the choice of biologics in asthma and COPD. And then finally, we'll discuss the barriers to use of biologic in both asthma and COPD patients. So let's discuss the lung immunology and what we have learned about regarding the immunology of asthma and COPD over the years. So let's talk about the impact of these two diseases. So asthma and COPD are very common. In fact, if you look at different statistics, they affect about 5 to 8% of Americans. Indeed, asthma affects about 26 million Americans, and many of these patients are children. We know that asthma doesn't spare any age group and any races. It tends to be more severe in African American and Hispanic Puerto Rican. Unfortunately, asthma continues to be uncontrolled, and the yearly cost of managing asthma is about $82 billion. On COPD is more impactful because it affects an older population. Usually patients with COPD are 40 years of age and older. The attributable cost of COPD in 2019 was $31.3 billion, but the costs are expected to expand dramatically. And majority of these costs come from the fact that COPD is a major cause of exacerbation, hospital admission, and also a major cause of indirect cost due to work loss, but also due to mortality. Unfortunately, both asthma and COPD continue to haunt us as clinicians, but also affect the healthcare system and, of course, the patient and the caregivers. Asthma continues to be uncontrolled in about 50% of the population, and many of these patients have recurrent exacerbations, which can affect their quality of life, increase health costs, and may lead to premature death. COPD, on the other hand, is a major cause of exacerbation. Despite adequate therapy, about 30 to 50% of patients continue to have what we call COPD exacerbations, which can lead to also worsening quality of life, progression of the disease, and of course, increased risk of mortality. Obviously, exacerbation of asthma and COPD are important events in the course of these two diseases, but their triggers may be different. Infections are a very common trigger in COPD. Environmental factors are common trigger for both asthma and COPD, but certainly other triggers may include pollution and other exposure. Cigarette smoke tends to be the major trigger for COPD. Of course, cigarette smoke is a problem in asthma, but majority of asthmatics, their triggers are more allergic triggers. Now, obviously, whether it's asthma, COPD, look at these two graphs here. Exacerbations from and hospital admission caused by these exacerbations are major events in the course of asthma, but more importantly, in COPD. COPD accounts for more all and acute hospital admissions. And unfortunately, these exacerbations, whether it's asthma or COPD, may lead to increased risk of 30-day and even 1-year mortality. In fact, when you look at COPD, 50% of patients with exacerbations leading to hospital admission are usually dead in 4 years after the hospital admission. So these exacerbations are impactful, and one has to understand the problem so that we can have a solution. Now, obviously, COPD and asthma are distinct diseases. While both can overlap in certain situations about 15% of the time, GINA and GOLD both are international strategies for management of asthma and COPD, has set definitions for these two diseases. And as you see, there's quite a bit of overlap in the definition in the fact that both diseases are heterogeneous. Both diseases are associated with chronic airway inflammation and airway obstruction, while COPD tends to be associated with progressive fixed sort of airway obstruction. Airway obstruction in asthma is usually reversible. Now, there are other differences, obviously, between asthma and COPD. The age of onset, the genetics of the disease, the symptoms. In asthma, it's usually episodic. In COPD, it's usually progressive. Smoke, as we mentioned, much more impact in COPD than in asthma. But certainly nowadays, we know that not only the clinical presentation, but the phenotypes and endotypes of these two diseases are quite different. In the next few slides, we're going to share what we have learned about the pathology, pathophysiology, and phenotypes and endotypes of these two diseases. While both these diseases cause airway obstruction, there are some similarities and differences between their pathologic manifestation. Obviously, in asthma, mucus plugging, goblet cell hyperplasia, smooth muscle contractility, and airway remodeling are very important, leading to airway hyperresponsiveness. In COPD, mucus plugging and airway inflammation are very important as well. There are differences in the type of inflammation in these two diseases, which we're going to discuss later on. But in COPD, there's destruction in the terminal lung, what we call alveolar breakdown, or what we call emphysema, that occurs in many patients who smoke and have COPD. If we go in more details of what happens in the airway of asthma COPD, you can see some similarities, but there are also some differences. Their symptoms, wheezing, cough, shortness of breath are very classic in asthma. Certainly, dyspnea and cough and sputum are very common in COPD, particularly those with chronic bronchitis. In both these diseases, airway obstruction is very prominent. Progression of lung function decline is more prominent in COPD than in asthma, and certainly exacerbations and reduced quality of life is common to both. When you look at the airway and the cross sections of the airway of asthma and COPD, there are some similarities in a way that remodeling, fibrosis of the airway, mucus hypersecretion is common to both. Airway hyperresponsiveness, although more common in asthma, can occur in COPD. And destruction of the terminal lung, of what we call emphysema, is mostly seen in COPD. On the right side of the screen, you'll see that there are several players here that drive the inflammation in both asthma and COPD. And for many years, we thought that this type of inflammation may be unique for asthma and another type of inflammation may be unique for COPD. But as you will see that there are some overlap, and indeed, while eosinophilic inflammation is most common in asthma, it can occur in COPD in about 30% of patients. On the other hand, while neutrophilic inflammation is the most common type of inflammation in COPD, it can happen in asthma, especially in those with severe asthma and those elderly asthma as well. The following animation provides a more detailed explanation of the immunology of the lung, cell types involved, and how they contribute to type 2 inflammation in asthma and COPD.
The lungs are an important immune site. Overreaction of immune responses can lead to diseases such as asthma and COPD. Airway epithelium is a continuous cell layer consisting of several cell types involved in immune responsiveness, including epithelial ciliary cells, basal cells, goblet cells, club cells, and neuroendocrine cells. The immune system of the lungs is comprised of two main arms: innate immunity and adaptive immunity. Innate immunity provides the first line of defense, acting rapidly and non-specifically. Adaptive immunity is a more targeted and slower response that develops over time and provides long-lasting protection. Both innate and adaptive immune cells act in the progression of COPD, with the innate response activating macrophages, neutrophils, and natural killer cells. This leads to alveolar wall destruction and mucus hypersecretion. Activated dendritic cells orchestrate adaptive immune responses, which can escalate into chronic inflammation. COPD can be categorized into endotypes based on the underlying inflammatory pathway. Type 1 and 3 are driven by neutrophilic inflammation. Type 1 effector cells produce interferon gamma and interleukin 12. Type 3 leads to increases in interleukin 17 and interleukin 22. Type 2, seen in a subset of patients, is driven by eosinophils and Th2 cytokines. Type 2 cells produce interleukin 4, 5, 13, and 33. These cytokine release profiles are potential biomarkers to classify endotypes of COPD. Th2 cells orchestrate the type 2 inflammatory response by producing key cytokines. Eosinophils release toxic granules that cause tissue damage, while mast cells release histamine, contributing to allergic symptoms. These immune cells and mediators are central to the pathophysiology of type 2 inflammation and are implicated in various conditions, including asthma and COPD. Recognizing the clinical implications of type 2 inflammation helps guide effective management strategies. By understanding lung immunology, clinicians can better classify patients based on inflammatory endotypes, use biomarkers such as blood eosinophil counts to guide treatment decisions, individualize treatment and optimize management for each patient rather than using a one-size-fits-all approach.
So therefore, our look on this asthma and COPD has sort of changed over the years. We know that clinically they may have similar presentation, but also within asthma and within COPD, there are multiple what we call phenotypes, the way the patients present. So not all asthma are the same. Not all COPD patients are the same. There are multiple phases or phenotypes or clinical presentation. In COPD, for example, phenotypes may include chronic bronchitis, emphysema, frequent exacerbators, those with comorbidities, those who have mainly dyspnea, those who are predominant airway disease, and those with predominant terminal lung or emphysema. In asthma, there's allergic asthma, late onset asthma, non-allergic asthma, and so on. So there are different clinical presentation. But more important, there are multiple endotypes, and these usually reflect the distinct biologic mechanisms that explain these phenotypes. These endotypes usually are driven by the different inflammatory cascade or cells, such as neutrophilic inflammation, eosinophilic inflammation, and others. And to understand the endotype, as clinician, we need certain biomarkers. And biomarkers are very important. These are objectively measured indicators of the biologic processes that help us identify what type of endotype we're dealing with. And after all, when we start thinking about treating these patients, we have to look at what their treatable traits. Is it predominantly airway obstruction that we're going to treat? Is it the exacerbations that we're going to prevent? Or is it the symptoms of these patients that we are going to target? So these are very important concepts now in the year 2025 and beyond, where we approach these obstructive lung diseases outside the box of what we used to in the past. So let's discuss what are the major phenotypes of asthma and also what do we know about the endotypes of asthma. This slide shows you that type 2 high asthma or type 2 asthma is about 50 to 70% of patients. These patients are characteristically allergen-driven, have allergen-driven asthma or eosinophilic asthma, then tend to be more steroid responsive, often more severe in some patients. On the other hand, about 30 to 50% of patients, they have non-type 2 asthma or what we call type 2 low asthma. These patients may have no eosinophilic inflammation in their airway. They may actually indeed have neutrophilic inflammation. They are usually poorly responsive to the common steroids, both inhaled and oral steroids. And unfortunately, there are not too many biomarkers to understand or at least detect these patients at this point. What about COPD? And what do we know about the phenotypes and endotypes of COPD? Well, we talked about the phenotypes of COPD, which include like chronic bronchitis, frequent exacerbators, airway predominant, or a lung predominant or emphysema predominant. But what we know about COPD, there are at least three types of inflammation that drives the disease. Majority of patients with COPD have what we call type 1, type 3 inflammation. Characteristically, these patients have neutrophilic inflammation in their airway, or if you're doing sputum induction and measuring it in sputum, and is driven by certain cytokines, including interleukin 1 beta, TNF alpha, and these patients tend to have poor response to steroids. This is the majority of patients with COPD. However, about 30 to 40% of patients with COPD have what we call COPD with type 2 inflammation. Type 2 inflammation here is driven by cytokines like IL-4, IL-5, IL-13, and these patients tend to respond better to inhaled steroids, but also better to certain targeted therapies that target type 2 inflammatory cytokines. So it's important to understand when we see patients with asthma and COPD, it's very important to understand which type of endotype we're dealing with so that we can pick the right treatment for the right patient. So summing it together, we have now understood the pathophysiology of asthma or COPD. More and more data are accumulating. We know that not all asthma is the same, not all COPD is the same. There are certainly multiple clinically relevant phenotypes, but more importantly, there are multiple endotypes. Type 2 endotype has now been well defined both in asthma and COPD. The non-type 2 endotypes need to be further studied. Certainly biomarkers for both are very important so that as clinicians we can identify these endotypes. And of course, treatable traits are very important to help us as clinicians choose the right therapies. And in the future, targeted therapies are certainly important. In fact, the future is now because we have several targeted therapies that we're going to be discussing later on in this module. So in summary, you can see that asthma and COPD are impactful diseases, not only that it affects patients' health and outcomes, but also the healthcare system, and impactful because many of these patients continue to be uncontrolled and have recurrent exacerbations. However, our look at both asthma and COPD has now changed in the year 2025. So I was going to ask Frank, can you tell us, since you've researched COPD now for more than 20 years, how has it changed in a way our look at COPD? What are the main changes that you see, and how is that going to affect clinicians' approach to this disease?
Yeah, that's a great question, Nick. Thanks for asking it. It's a pleasure always joining you with these activities. You're always very thoughtful in both these diseases. So the interesting thing is that I guess I would answer that question that 25 years ago, we knew that there was variation in the disease, but even beginning to understand mechanisms behind it was very speculative. And the dream was that we would be able to identify clinical subtypes or phenotypes and mechanistic cellular molecular subtypes or endotypes that vary, and then to the next level that are eventually targetable. But we really didn't know what direction we would be going with that. And now, we already have a first Th2 high drug approved, and others hopefully on the way. And then importantly, targeting other non-Th2 high mechanisms as well with other biologics. And within that, there are probably many different sub-endotypes. Even of Th2, we're learning there's probably subtypes within that, because Th2 is complex in and of itself, and one size even in that doesn't fit all. So I think now the reality is we are trying to implement the dream, and guaranteed even in 10 years from now we're not going to have it all solved, but we're at least in a direction that we're impacting human lives, decreasing hospitalizations, flare-ups, and importantly the cost of medicine, because if things are too expensive, we're not going to be able to deliver care to the broad number of patients that really need to have better treatments for their COPD and asthma. So in that light, I think we do sometimes we need to simplify a little bit to understand. Sometimes we oversimplify, and I'm wondering, with regards to Th2 high mechanisms in eosinophilia, there's really been an important effort, and I think even within the FDA, to recognize that Th2 high COPD should not just be considered the same as asthma COPD overlap or Th2 high asthma. And I wonder, is there a mechanistic foundation that high eosinophils and Th2 mechanisms in asthma are different than COPD?
Yeah, no, I think you're right on asking this question, Frank. Obviously biomarkers are very important to help us, whether it's asthma or COPD, to identify the endotype that we're dealing with. Currently, there are only few biomarkers we use in asthma, blood eos, as you mentioned, sputum eos and FeNO, and maybe IgE. In COPD, the role of eos is rather new. For many years, we thought this is a disease that is characterized by neutrophilic inflammation, and actually eos were less thought of. But now we know about 30% of patients, even if you rule out asthma, even if you rule out asthma COPD overlap, they do have peripheral eosinophils that are higher. Cutoff is 300 that we use. I think it's more of an artificial cutoff, but that's what we use based on trials. But the big question is the role of EOs in this type of COPD, type 2 COPD we call it, different than what it is in asthma? We know in asthma EOs play a major role in propagating the disease. It's not the only inflammatory cells. We know that we target eosinophils, whether targeted therapies targeting only eosinophils they do help in asthma, but do they do it in COPD? Right now, there are evolving studies looking at this. Um, People think that blood EOs are very good biomarkers in COPD, no question about it. The higher the EOs, the higher risk of exacerbation, the higher risk of readmission, the higher risk of decline in lung function. But at the same time, the role is maybe different than in asthma in a way that there are only few studies now showing the population of eosinophils in COPD may be more resident rather than inflammatory eosinophils in asthma. I think we're going to have to see, because right now with only one targeted therapy approved in COPD and many others are in the pipeline, we'll see if targeting EOS is the right thing to do, only EOS, rather than targeting other pathways. I think but it's very important for our listeners to know that type 2 COPD is not asthma. It's a different phenotype. These patients are at risk of exacerbation. And again, they don't have to have any asthma features, even though shortness of breath and cough and wheezing can be present in these patients. But they don't necessarily have to have asthma to have type 2 COPD. It's a smaller group, 30%, but a very impactful group of COPD patients.
Yeah, that's great. And the emerging clinical trials really do show that it's a group that we could impact initially with inhaled steroids, but now with these biologic treatments to the next level.
Yeah, it's true. Like blood EOs right now in both asthma and COPD are prognostic biomarkers. They are predictive biomarkers. They predict response to inhaled steroids, like you mentioned, and maybe some targeted therapies. Um, Whether the question is whether the role of these agents, these biomarkers, is the same as it is in asthma remains to be seen.
Great.
All right. So I am Dr. Stephanie Christensen, and I am a pulmonologist and associate professor at University of California, San Francisco. And today we're going to be talking about biologic targets for obstructive lung disease.
Hi, my name is Nick Hanani. I'm professor of medicine at Baylor College of Medicine in Houston. It's a pleasure to be with you today. to discuss type 2 inflammation and type 1 and type 3 inflammation, both in asthma and COPD. And we're going to talk about unmet needs as well as the role of biologics in severe asthma and also in severe COPD. Let's start with the asthma pathophysiology. What we've learned over the years is that asthma is driven by several cells, or inflammation in asthma is driven by several cells and cytokines or mediators. What we know is that 70% of patients with asthma suffer from what we call type 2 inflammation. About 30% have non-type 2 inflammation, and both types of inflammation can cause the changes that we see in the airway of asthmatics, the airway hyperresponsiveness, remodeling, mucus hypersecretion, and bronchoconstriction. Type 2 inflammation can be driven by other adaptive or innate immune response, leading to eosinophilic inflammation in the airway. And non-type 2 inflammation usually is characterized more with neutrophilic inflammation. Similarly, in COPD, more now we know that both types of inflammations are important. However, in COPD, about 70% of patients have what we call type 1 and type 3 inflammation, usually characterized by neutrophilic infiltration, both the airway but also in the airway lumen. And these patients have characteristically mucus hypersecretion and airway narrowing because of the small airway is usually inflamed. However, more recently, about 30% of patients with COPD are found to have what we call type 2 inflammation, very similar to what we see in asthma. This type of inflammation in COPD is driven by several cells and cytokines, including IL-13, IL-5, and IL-4. But also, this type of inflammation has been characterized by mucus hypersecretion and airway remodeling. Obviously, the changes in COPD and asthma in both the airway, but in the lung architecture are classic. In COPD, we have more destruction in the terminal lung, leading to what we call emphysema. But remodeling and restructuring of the airway can occur in both asthma and COPD. So what is it for clinician? Obviously, deciding on what phenotype and endotype we're dealing with is very important so that we can appropriately choose the treatment for patients. And you can see that on the slide that there is a link between endotype and phenotype. And for us as clinician, we have to use certain tools. And these tools are obviously the clinical presentation to define the phenotype, but biomarkers that may help us define the endotype. And these biomarkers can be usually measured in the blood. We have limited biomarkers right now. We'll talk about one of them, that's blood eosinophils, but there are other biomarkers such as imaging biomarkers and CT biomarkers that are being looked at in the research arena. And more important is more biomarkers are on the way to help us identify these phenotypes and endotypes. For example, in asthma, blood eosinophils and exhaled nitric oxides are very important biomarkers of type 2 inflammation. The higher the FeNO levels, FeNO is a gas that can be measured, and more than 25 parts per billion is considered high in adults. The higher the FeNO level, the higher risk of exacerbation. So is the level of blood eosinophils. In general, in asthma, blood eos more than 150 cells per cubic liter is considered high. And as you see in this study, when they combined both blood eos and FeNO, there is a composite biomarker that predicts exacerbation. This is very similar to what we've seen in COPD, where blood eosinophil in COPD are predictors of exacerbator. If you measure blood eosinophil in COPD, and the higher the blood eosinophil, the higher risk of exacerbation. In general, we use a cutoff of 300 cells per cubic liter in that population. These patients with high eosinophils are at high risk of exacerbation, but also high risk of readmission to the hospital based on epidemiologic studies, but also at high risk of a rapid decline in lung function. And also blood eosinophil in COPD is a good predictor of response to certain medication, and that's inhaled corticosteroids. However, despite being on appropriate treatments, and appropriate treatments in both asthma and COPD include inhaled steroids and long-acting bronchodilators, in spite of that, we continue to see unmet needs with treatment for asthma and COPD. These unmet needs include the fact that despite adequate therapy, many patients continue to have exacerbation, hospitalization, continue to have symptoms. Unfortunately, none of the treatments we have right now can sort of shift the pendulum. We don't have a cure for these diseases. We can't affect the natural history of the disease. So there are unmet needs leading us to look more outside the box, to look at, can we actually target the endotype? Can we target the type of inflammation these patients have with targeted therapies? And certainly biologics have allowed us to probe into that. And with that, Dr. Christensen, Stephanie is going to go over some what we have learned about biologics in asthma and in COPD.
So, as we said, there's actually multiple drugs now that are available for asthma. And I think, some of how we think of using these drugs is based on their mechanism of action. And so we can use biomarkers to understand which drug might be suitable for which patient. So, omalizumab, we have to use IgE to really know, is that drug going to work in our patients? And we also might think of other drugs or other conditions that some of these drugs are approved in, because a lot of those are comorbid with asthma. So if a patient has both, then it may limit which group of drugs that we want to use. So in the case of omalizumab, urticaria and nasal polyps and food allergy may make this more of a drug that we want to use. Mepolizumab, rezolizumab, and benralizumab, again, work well on patients who are eosinophilic. And so meaning that we want to use the eosinophil to guide our treatment. And again, some of these drugs are also approved in other conditions like the hypereosinophilic syndromes, EGPA. And so that may guide, do we want to use these drugs? Like benralizumab was recently shown to be non-inferior to mepolizumab in EGPA. So that might be, those two drugs may be one that we want to consider in a patient who we're suspecting could have EGPA along with asthma, and certainly nasal polyposis. We may want to be considering mepolizumab as well. Dupilumab. So again, we look at eosinophils, although we can also look at patients who have elevated FeNO. And actually, if I'm thinking, they have eosinophils and elevated IgE, I might be thinking about either dupilumab or tezepelumab for that patient. The other thing being with dupilumab is that it works in patients who have other conditions. So atopic dermatitis, chronic rhinosinusitis with nasal polyposis, eosinophilic esophagitis, COPD. So this again may be a drug where do you have something else where I'm considering, do you have more than one condition? And I think in a patient who I'm thinking maybe has asthma, or have they been a smoker, and am I actually concerned about COPD, this may be a drug that I'm considering. And tezepelumab, is approved in patients who don't have eosinophilic inflammation. And so although it does seem to work better in patients who do have elevated eosinophils, so this drug, again, we're looking at biomarkers to help us kind of guide how to use these drugs in asthma. But it's nice that we have multiple options for our patients. And sometimes if one drug isn't working, we can consider switching to a different drug. So next, we're going to get an animation of the mechanisms of action of the different biologics. So this will provide a more graphical, detailed description of these mechanisms of action. All right, so let's go through some of this data on the clinical trials of the biologics in COPD. So the first we're going to go through are the Boreas and Notus trials of dupilumab, which again is targeting the IL-4 receptor, which binds IL-4 and IL-13. So this drug is thought to, again, reduce the IL-4 and IL-13 cytokine signaling. So Boreas and Notus were actually kind of twin studies, and that the eligibility for both studies was pretty much the same, the inclusion criteria. So first of all, you had to have a history of smoking, so 10 pack years. They had to be on triple therapy, meaning an inhaled corticosteroid, long-acting antimuscarinic, and long-acting beta agonist for at least 3 months. There was you could be on just LABA/LAMA if you had a physician diagnosed reason to not be on the inhaled corticosteroid, but that was really only in about 1% to 2% of patients. So almost everybody here was on triple therapy. And they had to be considered in that kind of gold E group from the GOLD recommendations, that exacerbation prone group. So meaning greater than or equal to 2 moderate exacerbations, so requiring either seeing your physician, getting oral steroids or antibiotics, or greater than or equal to 1 severe exacerbation, so either hospitalized or emergency room visit. They all had to have chronic bronchitis. And this, I think, was done so that they had a patient population that they thought would actually be more likely to be type 2 high. They couldn't have any history of asthma, at least not diagnosed asthma. Whether some of these patients may have had asthma could be something that's a discussion point, but they never had a history, so they were never treated for asthma. And then blood eosinophils of greater than or equal to 300. So a little different than asthma, where the points tend to be lower for the blood eosinophil counts at 150. But what they found was that across Boreas and Notus, that they had exacerbation reduction, 30% in Boreas and 34% in Notus. And they also saw an increase improvement in the lung function, so in your FEV1. And that happened actually relatively quickly, within 2 weeks in both Boreas and Notus. So suggesting that we have an objective finding that this drug is working at least within a couple weeks of when you get it. And this is just a little bit of additional data on who we were seeing this drug working in. And, it did seem to work in both current and former smokers. It also seemed to work in patients who had physician-diagnosed emphysema, both in patients who did and who did not have that. Not suggesting that it's working on that already destroyed lung tissue, but that even in a patient who has a diagnosis of emphysema or seems to have emphysema on their CT scan, that this drug may still work if they otherwise meet criteria. The pooled analyses showed that there were improvements in your symptoms and quality of life, which is potentially exciting for our patients who are going to care about their quality of life and how they're living. And that safety was similar between placebo and the dupilumab arm. So kind of similar to what we're seeing in asthma, that we have similar safety. Now, the anti-IL-5 story is a little bit more complex. So in Metrix and Metrio, which were the first phase 3 trials to look at mepolizumab, they actually they looked at a slightly broader group. So they kind of similar otherwise to what we saw in Boreas and Notus, that 10 pack years, they were on triple therapy, they had that exacerbation prone phenotype, that they did not have asthma. But they looked at patients who had greater than or equal to 150 at screening or 300 in the last year. And they had some mixed results. 18% reduction in exacerbations in one, but not both of the trials. So the one showed no difference in symptom scores. But they did some post hoc analyses, which suggested that there was a responder group, that if you had greater than 300 EOs at the time of screening, that those patients, and you had chronic bronchitis, that those patients seemed to have a better response to the drug. And so what that has meant is that they did another phase 3 trial where they were specifically looking at that group with elevated eosinophils greater than 300. And this has read out that there's top line data back that has been announced by the company that suggesting that they have reduction in exacerbations, but we don't know anything else about what's happening with that study, like how far is the exacerbation reduction, what did the patient population look like, what were the additional outcomes that were positive or negative. But hopefully we'll see that soon. Benralizumab, so kind of a similar story here, that they looked at, again, a very similar group. 10 pack year smoking history, dual or triple therapy, and exacerbation prone. They had to be symptomatic, in this case have an MMRC greater than 1. Current diagnosis of asthma was excluded. And here they used a blood eosinophil count of 220 or greater. And again, they didn't actually see the responses that they wanted. So no significant changes in exacerbations, although they did see improvements in lung function. And they actually saw that there was a responder group. It actually tended to be the patients with higher eosinophils that were particularly exacerbation prone, that seemed to be that kind of group that responded better. So there are currently additional phase 3 trials that are ongoing. And interestingly, in both asthma and COPD, and I get asked this question a lot about, hey, do you ever see these drugs potentially being used at the time of an exacerbation. So there was a phase 2 trial where they used eosinophil-guided therapy in both COPD and asthma, definitely more asthma than COPD, where they looked at giving this drug during an acute exacerbation. It failed to reduce in the pooled group overall, but it did look like the point values were a little bit better, that it was 45% versus 74% with prednisone alone. So we're going to move on and talk about the alarmin therapies. So now, like I said, alarmin-based therapies are somewhat upstream of the type 2 cytokine signaling pathway, starting kind of with injury to some of the cells, like the epithelium in particular, but even the endothelium and other cells can release some of these alarmins when they are injured. So they are ready to go respond to any injury, an inflammatory response. And anti-TSLP, so tezepelumab, again, is used in asthma in both type 2 and non-type 2 high asthma, exacerbation-prone or severe asthma. Now, they've studied this in the phase 2A course study in COPD. So eligibility, pretty similar looking here. So triple therapy, greater than or equal to 2 exacerbations, moderate to severe airflow obstruction, and 10-pack years smoking history. However, here we're looking at any blood eosinophil count. All those patients with any blood eosinophil count can be included. Now, they did not meet their primary endpoint overall. However, what is kind of interesting here, and I think this is what we use a lot of phase 2 trials for, is that there is some suggestion that if you had blood eosinophils greater than 150 and even better responses with higher eosinophils, that those patients seem to have, again, point value, better responses to the drug. So in reducing exacerbations. So some suggestions that this drug may work better in a type 2 high patient population in COPD. But again, that would require phase 3 studies to really understand that. Now we're going to talk about these 3 anti-IL-33s. So itepekimab and tozorakimab target the IL-33 directly, and astegolimab, which targets the receptor. So itepekimab was studied somewhat recently, just published in 2021 in a phase 2A trial, and has ongoing trials, phase 3 trials currently underway, and should be, again, read out somewhat soon in the next couple years. So itepekimab, again, we kind of looked at a very similar patient population, however, not with EOS high. And what they saw was that overall, there was no change in acute exacerbations. However, and this is what we'll see in kind of all of these studies, they did some subgroup analyses to look at who their responder groups might be. And with this drug, they actually found that there were reductions in acute exacerbations and FEV1 improvement in looking at just the former smokers alone. So again, these are post hoc analyses, not the primary analysis, but suggesting that this drug may work across eosinophil groups, not just type 2 high in just former smokers. But I think the phase 3 data will really help us understand that better. And then again, tozorakimab and astegolimab, there were phase 2 trials for both of those. So for tozorakimab, there was Frontier 4, again, small studies, so 135. They looked instead at, it was not the same exacerbation prone group where you had to have at least 2 moderate or 1 severe. You could have 1 or more moderate or severe in the past 2 years. So they were a little bit more lenient for this phase 2 trial, and you had to have chronic bronchitis. Their primary endpoints were not met. However, they did see that particularly in the patients with higher blood eosinophils, and I think in the group that you would normally treat with the biologics, so that gold E group or exacerbation prone 2 or more, that group did seem to have better improvements in exacerbations. So important for thinking through their phase 3 trials and what they're hoping to see from those. However, they didn't meet their primary endpoints. And then astegolimab, which targets the receptor for IL-33, ST2, was looked at in the COPD STOP study, small group of patients, 81. And in this phase 2 trial, they actually considered a much broader patient population, moderate to very severe COPD, but they did not have to be exacerbation prone. Their primary endpoint was exacerbations, and that was not met. However, they again looked at some subgroups. And here, kind of interesting what they were seeing. So they're seeing kind of some differing effects in type 2 low or eosinophil low patients and type 2 high or eosinophil high patients, where they actually were seeing exacerbation reduction that was better, again, point point value is not significant, but better in the EOS low group, so the patients with the low eosinophil groups or low eosinophils, whereas they were seeing improvements in lung function and symptoms in the patients with higher eosinophils. And I think they cut off at 170 because that was their median or mean value. But basically, we're seeing some differing effects here. So again, will be interesting to see what they see in their phase 3 studies because these are small groups. So it's hard to know what we're going to see exactly in the phase 3s, but it's some interesting trends that might suggest that some of these drugs might be useful in different groups of patients. So when we're thinking of putting our patient first, who would you use what drug for? I think as these phase 3s read out, that will give us more information. Hopefully, we'll be able to target a broader group of patients. All right. And so this was just a network meta-analysis on the different biologics. And I think we have dupilumab that we know reduces acute exacerbations, change in lung function, change in symptoms, and seems to have a good safety profile. And I think really thinking about all these other drugs, I think it's going to be very interesting. Really, we're going to need the phase 3 data to really understand how well are they working. Are they working just as well as dupilumab and in what patient groups to really understand which groups are we going to target. But I think we think of the anti-IL-5s similarly targeting kind of that type 2 high inflammation, whereas these alarmin-based therapies, anti-TSLP and anti-IL-33 may target broader inflammatory responses, but we'll just have to see with the phase 3 trials. So based on the Boreas and Notice data, the gold recommendations for biologics have changed this year and do suggest that we may have another option for our patients who are gold E, meaning they are exacerbation prone and continue to exacerbate despite what we are doing. So in patients with a history of exacerbations, chronic bronchitis, and eosinophil counts of greater than or equal to 300, that dupilumab may reduce exacerbations, improve lung function and quality of life, and might be a useful tool in a patient who we already have optimized on our other, or not optimized because they're continuing to exacerbate, but we already have on all of our other inhaled therapies in triple therapy and are doing what we can as far as making sure they're using their inhalers correctly and optimizing them as far as their comorbidities, pulmonary rehab, other options, non-pharmacologic options for them. Dr. Hanania, I think, we've just gone through all of the data on biologics, particularly seeing all kind of the new exciting data in COPD. And, I think you've had a lot of experience using biologics in asthma. And I think I wanted to hear from you kind of, how you think through in asthma, kind of which drug you're using and how you're thinking about how you might apply that in kind of as we see a changing landscape in COPD, how you may apply that to COPD.
Thank you for the question, Stephanie. And I agree, it's an exciting time that we have all these opportunities. We've dealt with asthma now. We have 6 biologics approved in that field in the United States. And in COPD, things are moving. We have only one. But our experience in asthma with biologic has taught us a lot about patient selection. So it's obviously these two diseases are different. Inflammation in asthma and COPD, as we talked about, may be different as well. The use of biomarkers may help us identify which biologic to choose. And that has been very, very helpful in asthma. We look at biomarkers, we look at whether the patient has comorbidities. Certainly some biologics in asthma are approved for more than one condition other than asthma, and often these conditions coexist with asthma. Certainly we're dealing with different type of population, and probably the cutoff of biomarkers, especially when it comes to blood eosinophil, may be different. You've researched COPD for a long time. You understand that maybe the role of eosinophils in asthma and COPD may be different. It's an important biomarker, but maybe the cutoff should be different, and this is based on the clinical trials that you've outlined. But I think the fact that what we learned in asthma is we put the patient first, and actually discussing with the patient, doing shared decision making when you choose a biologic, especially if there's more than one choice for a biologic is important. Obviously, there's lots of hoops that we have to jump over to get these approved, as you know, with the prior authorization, patients' cost out of pocket, is all these things we've learned a lot in asthma will certainly come for COPD. And probably it's a bit of a challenge, I think, in the COPD population. In fact, I wanted to ask you that now we have one biologic approved for COPD. Where do you see this going in the future, and why do you think the COPD population is a bit more challenging than the asthma population when it comes to biologic, or do you?
No, I mean, I think, I think that's a really good question. And I think you're right, in that, we certainly have those really kind of difficult to treat asthma patients too. Almost some of them almost kind of look more like COPD, right? Even though maybe they were never a smoker. And so some of that might be that you really do have more mixed inflammation in COPD, where we do really have patients who maybe have less type 2 inflammation, where you have a lot more type 2 inflammation in asthma, where we're really targeting that. So I think that's one thing. And that means that maybe some of our biologics that are targeting kind of hopefully targeting more broadly than just type 2 inflammation. I think there is some hope that maybe the anti-IL-33s are targeting more broadly, and certainly anti-TSLPs, although we're seeing that that's even in COPD in the phase 2s are, working better in the type 2 high population or the eosinophil high population. And I do think the other kind of major issue with the COPD patient population is a lot of them, they're older. There's certainly, I mean, we see this in asthma too, but all of them have fixed defects and have fixed disease that they're not going to get some of that back. And oftentimes, this developed somewhat insidiously. So they've got deconditioning, and so you've got a lot of, and then have other comorbidities like cardiovascular disease, depression, obstructive sleep apnea. And so I think you've got issues with maybe that we need more broad inflammatory targeting, at least in some patients, or different types. And so I'm hopeful that as we talked about for the asthma patient populations, that we may have different endotypes that we can target with our different patient populations or our different biologics. But I think then there's also, the issue of what can we make better versus what can't we make better, and making sure that we're kind of thinking through those things with our patients, and certainly using biologics in conjunction with our other kind of non medical therapies like pulmonary rehabilitation, or just exercise in general, making sure that we're getting our comorbidities treated so that we're actually kind of treating that whole patient, as you were saying, putting that patient first, because there's a lot of things we're not going to just treat with the biologics. I don't know how have you been thinking about it in the same kind of way, or are you, what are you
Yeah,
thinking?
yeah, no, all these are important. There's opportunities with new treatments for COPD, but there are challenges. Can't claim that it's all smooth riding, because, the population we're dealing with is certainly much more comorbid, older. Some of my patients have cognitive dysfunction, sometimes physical dysfunction, so self-injections at home may be a problem. Cost, many of them are on government insurance, and certainly cost and out of pocket with all the other medications they're on. So these are some challenges, but I'm very excited that we have at least some kind of a light at the end of the tunnel that we can probe in some of these patients. It's certainly not an easy one, but it's a journey that I think we've been waiting for, because we have good drugs now for COPD, but certainly about 50% of these patients, as you know, Stephanie, despite triple therapy, which are important in addition to the treatment of COPD, they continue to exacerbate. So I think there is a big unmet need, and I look forward to seeing more and more come on board in a way that will improve the opportunity for choosing other treatments.
Absolutely. I think it's great that we have new potential therapies for some of our patients, and I know I'm excited for that as well, and hopefully our patient populations are excited too. So that we may have more to help them with. So yeah,
Yeah,
thanks.
one of the biggest need also is to find more biomarkers. Right now, we're stuck with blood EOs, and maybe the role of pheno is now emerging in COPD, but we need other biomarkers, especially for type 1, type 3 inflammation, and I think that's a big unmet need as well.
I think you are not wrong. I think we know that blood eosinophils are not, they're already imperfect in asthma and COPD. It looks like maybe even a little bit more so, that they don't mark the type 2 inflammation as well, and certainly are lacking for the other types of inflammation. So I'm certainly hopeful that we'll be developing more over the future. But I think then, with all these potential exciting opportunities, that does kind of um, lead groups in industry and in academia to be more interested in finding some of those things that now that we have a good signal that we can help patients with some of these things. So, welcome. I'm Dr. Stephanie Christensen, and today we're going to talk about optimizing the choice of biologics in asthma and COPD. So let's go on and do a case. So we are going to meet Clara. And so Clara is a 71-year-old woman. She has some pretty kind of typical symptoms of COPD: cough with mucus production, dyspnea, wheeze, chest tightness. She also has sleep disturbance, fatigue, anxiety about having exacerbations. So very typical of some of our COPD patients. She thinks some of her symptoms are just due to being old. Her BMI is 29, so she's in the overweight category. She has a 15-pack year smoking history. So her exacerbation history, she has 2 moderate exacerbations in the past year, meaning that she has 2 exacerbations that required a visit to her doctor to get either oral corticosteroids, antibiotics, or both. So that puts her in the gold E category for the gold diagnostic algorithm. Her laboratory assessment. So she, on pulmonary function test, she has a forced vital capacity of 2.7, a post bronchodilator FEV1 over FVC of 0.67. So she meets the criteria for obstruction. Her post bronchodilator FEV1 is 1.8 or 65% predicted. So again, she's obstructed. Her blood eosinophils are 320, so that would kind of qualify her as in that type 2 high or blood eosinophil high group. And her echocardiogram has a low ejection fraction. Comorbidities, so kind of comorbidities that I oftentimes think a lot about in our COPD patients. So diabetes and osteoporosis, so things like depression and heart failure are kind of common issues that I oftentimes think about in my patients and want to make sure that I'm getting under good control. Her current treatment, so she's on actually pretty optimized inhaler therapy. She's on triple therapy, meaning an inhaled corticosteroid, a long-acting beta agonist, and a long-acting antimuscarinic, as well as albuterol nebulizers as needed. And I think we'd have to delve into, is she using her inhalers appropriately? Is she using them as prescribed? Both, is she taking them in the correct way? And is she missing any doses? Okay, so here are the images of Clara's lungs. So certainly we get CT scans in many of our COPD patients, oftentimes for lung cancer screening. And in this case, we actually have inspiratory and expiratory scans. So we have both evidence of airway wall thickening, so kind of a evidence of mucus impaction or inflammation of those airways, as well as, because we have the inspiratory and expiratory scans, we can see that there is air trapping. Sometimes with mosaicism, I also worry about vascular disease, but here we actually see that she's got diffuse gas trapping. So evidence of kind of small airway obstruction. So diagnosis and treatment. So diagnosis, so I think she's got COPD, and because she's got those blood eosinophils greater than 320, and, even if we were seeing other characteristics of her COPD, like emphysema, she's got those blood eosinophils greater than 320. She's got an exacerbation history, and she's got chronic bronchitis. So this kind of puts her into that COPD type 2 category. So the things that I'd be thinking about her is first, really recommending pulmonary rehab in a patient who's a frequent exacerbator. That can be really helpful. Avoiding secondhand smoke, making sure that she's getting her vaccinations. Certainly very critical to ensuring that we've got exacerbation prevention. And then she may be, if we have if we're making sure that she's taking her inhalers correctly and that she's otherwise optimized, that she might be a candidate for a biologic. All right. And just kind of going through that, I think that case was really brought up when we're starting a biologic, how we think through that. So first we want to confirm the diagnosis. So she's got COPD, she's got type 2 inflammation. And so the first thing that I'm doing is really making sure that I'm optimizing her current regimen. So triple therapy or an inhaled corticosteroid, long-acting beta agonist, and long-acting antimuscarinic is kind of that first line for exacerbation prone COPD with elevated eosinophils. So we want to make sure she's taking it, make sure that she's got a good technique, and that can actually take a couple times, either with myself or a physician or with one of our pharmacists or our respiratory therapists to really go through how to take that appropriately, optimize her comorbidities and her triggers. So secondhand smoke, is she around that? Is she getting exposed to a lot of viruses? Can we make sure that she's really mitigating those things as much as possible and optimizing her comorbidities? So making sure depression gets treated, making sure her cardiovascular disease is treated. And then we think about things phenotyping, endotyping. So we've already got the blood eosinophils in Clara. So we want to make sure, and I'm checking blood eosinophils in a lot of my patients because I will be sometimes surprised that they are elevated in some patients where I may not have expected it. So I'm really checking that in all of my patients, particularly the frequent exacerbators. And then confirm biologic eligibility. So based on, is she an exacerbator or does she have elevated eosinophils? And then, of course, we have to go through our local health system criteria that there may be some limitations there, and patient preferences. In asthma, we actually have, multiple choices. And so some of those preferences may be based on timing, or can you take it at home, or do you have to come in to do that, to use the drug? So there can be some preferences there. Route of administration, most of them are given injectable now. And thinking about parameters for response, like, are you going to have symptomatic response? Are we just looking at exacerbations? Then we're kind of going back and forth and trying to understand, okay, over the next couple of months, how is this going for a patient? Are you seeing anything like side effects or adverse reactions? Is the patient feeling better? Are we expecting the patient to feel better? And, it may take a little time. And in certain patients, like a COPD patient who already has fixed airway defects, I think we want to make sure that we're being careful with saying, you may not be completely better, but let's level set here. And are you starting to be able to do some of the things that you couldn't do before? Are we preventing exacerbations? So thinking through all those pieces. All right. So when we're thinking about choices for biologics in severe asthma, we can use both phenotyping and our biomarkers. So I think this is a schematic from the New England Journal from 2022 that I think does a really nice job of helping us kind of think through how to use biologics in asthma. And, they start kind of at the highest level with, are you a patient who's managed on oral corticosteroids, where you may actually, blood eosinophils, at least at that time, may be suppressed just based on your oral corticosteroid use. And those patients can be thought about somewhat differently than patients not on oral corticosteroids. But then our kind of next level, if you're not on oral corticosteroids, is to really be looking at that blood eosinophil level. So looking at that biomarker first. And we can kind of put that into three different buckets. So there's the patients who have very, very high blood eosinophils. So in this case, they use a cutoff of greater than 1,500. Sometimes people will use a slightly lower cutoff, but I would say 1,000 to 1,500. And that patient population, I think we were thinking, is there something else going on, like a parasitic infection? hypereosinophilic conditions. And so we want to be ruling those things out. But in that patient population, I might be choosing something that is specifically targeting the eosinophil, so an anti-IL-5 or anti-IL-5 receptor blocker. In the patient population that is kind of considered type 2 high, but not in that kind of really high eosinophil range. So we're talking about 150 to 1500 or so. We really have a lot of options where we can be thinking about our anti-IgEs, our anti-IL-4 receptor blockers, our anti-IL-5s, our anti-IL-5 receptor blockers, or our anti-TSLP. So we actually have a lot of options. And then I think when we get into that patient population that has low blood eosinophils, then we're talking about a patient population where we may have fewer options. So if they have low blood eosinophils and an elevated exhaled nitric oxide, we've got maybe a couple more options. Here we can be thinking about, first of all, do they have allergic disease or not? If they do have allergic disease, then we still actually have three options: anti-IgE, anti-IL-4 receptor blocker, or an anti-TSLP. If they don't have that allergic phenotype, then we wouldn't just want to give an anti-IgE, which is really kind of targeting that allergic inflammation. So then that would be ruled out, but the other two are still options. And now if we have a patient who's basically low for everything, so low eosinophils, low FeNO, then we've really got anti-TSLP can be used in all those patients. And if they have allergic inflammation, we can still consider an anti-IgE. So we actually have several options for our patients to kind of consider based on looking at their biomarkers. For biologics right now, the anti-IL-4 receptor blocker, which kind of targets IL-4 and IL-13, and really kind of a slim patient population really fits into that algorithm. They have to be a frequent exacerbator, have eosinophils greater than 300. But again, that's kind of the patient population I'm really wanting something, I might really want to be using something additional in. So I'm really looking for it. Like, do you exacerbate? Do you have elevated eosinophils? And so it's really important to be thinking about the blood eosinophil level. And I would say that right now we're seeing 300 as being kind of that important level. We also want to really be thinking about, okay, are you already on an inhaled corticosteroid? Are you on that triple therapy? And there may be in the future, we may be interested in, are you a current smoker versus former smoker? And is that going to help us differentiate which biologic to use? Although currently with what we have FDA approved, I think we can use that in both. So I think just kind of reiterating that this patient assessment, are you an exacerbator? Do you have elevated eosinophils? Maybe do you have a chronic bronchitis phenotype? Those are kind of key factors that I think about.
Hi, I'm Dr. Frank Sherba. I'm a professor of medicine at the University of Pittsburgh, and I've had a long time interest in COPD. We've been waiting a long time for this more precision approach and the emergence of biologics, so I'm really proud to continue this discussion. I'll be talking now that we've decided, hey, maybe there are biologics that are appropriate for our patients. What are those barriers and the potential mitigation of those barriers? So what are our goals of management in asthma and COPD? And while in the two diseases there may be a bit more emphasis on one versus the other, in fact, our goals are really similar in the end, and that is reducing the symptoms to improve quality of life and functional status. When we can improve actually lung function along with it, that's always a good thing, and it usually leads downstream to many of these other outcomes. It's more likely in asthma than COPD that we can improve lung function, but we still can have somewhat of that impact even in COPD. Management of comorbidities, now that's something more of an emphasis in COPD, and it can really complicate the management because cardiac issues and other systemic frailty issues can result in dyspnea and overlap in symptoms with what we can manage in COPD. And so it's important to manage those as well as the specific lung symptoms. And then symptom control, daytime symptoms, nighttime awakening, problematic in both disease. And then we want to reduce the flare-ups, the exacerbations, a problem in both conditions, the emergency room visits, and then treatment-related adverse events. thrush with inhaled corticosteroids and volume overload with admissions to the hospital can result in problems. Hospitalizations we always want to avoid. That goes along with decreasing exacerbations. And then ideally we want to give therapies that minimize disease progression. And I think we're more aware of that in asthma. There's a goal for that in COPD. We believe we're getting there, but I think we need more data and long-term follow-up to know for sure. And then, of course, mortality, particularly in COPD, is something in the end, if we do everything else right, we hopefully can reduce. And so again, to some extent, this is a repeat, but self-management strategies involve really influencing even friends and family that these patients get their information from, social media, advertising. And sometimes you have to overcome false or negative stereotypes of the therapy you want to move forward with before you can impose it. Financial implications, I mean, these are critical. If a patient has a $600 a month copay, we're going to have to work hard on that to convince a patient that this is the right therapy or do whatever we can to overcome those financial barriers. And then really even physical and mental health issues that interfere with a patient understanding and complying with the therapy. So that shared decision making, really knowing your patient, having them understand what your goals are and the decision you believe is best for them to move forward. And then to educate them on self-management and appropriate health care. Education programs could range from advice on exercise. I mean, if we don't optimize all these other aspects, you're not likely that moving to biologics is going to have as much an impact on their overall quality of life, including cognitive behavior elements, multidisciplinary rehab programs that include smoking cessation, education on diet, etc. Ongoing nurse support when patients have questions, because even if you have covered everything, which you probably haven't, they're going to have questions. They're not going to have recorded everything that you think you have gotten across. And so to have resources for them to continue to lean on. And then to really write things down sometimes and optimize their care plans. So the one area in COPD that is really critical is appropriate involvement in the patient in the therapeutic decisions. And these become even more important, I think, with biologic therapy because there's a lot more involved with that than even just the maintenance therapies that we already have problems with. So, being a good clinician that you don't learn about so much in the textbooks involves really effective communication. And that includes an understanding of these kind of obtuse concepts of high eosinophils and these treatable traits that allow some patients to be amenable to the right therapies and others not. But also understanding the patient's treatment priorities. Again, if they want to march around the lake with their grandchildren, we may not have the right therapies in COPD to do that, but we can reduce those bad days. We can reduce the hospitalizations. And so setting expectations really is critical. And factors that really affect ultimately the adherence and overcome those barriers to resistance starts with getting your patients trusting in the healthcare provider, educating the patient so they understand the big words that are familiar to us, but that they really need to have a deeper understanding of to help make the shared decision. And that includes knowledge and health literacy. To understand their perception of the illness and how the disease affects them and their social interactions and quality of life. And then to really then go into that shared decision making so that they've bought into it. They understand the potential benefits and the potential lack of the expectations that may be more realistic. And then to give their confidence, their sense of self-efficacy in moving forward with whatever therapy that we choose. And so again, to some extent, this is a repeat, but self-management strategies involve really influencing even friends and family that these patients get their information from, social media, advertising. And sometimes you have to overcome false or negative stereotypes of the therapy you want to move forward with before you can impose it. Financial implications, I mean, these are critical. If a patient has a $600 a month copay, we're going to have to work hard on that to convince a patient that this is the right therapy, or do whatever we can to overcome those financial barriers. And then really even physical and mental health issues that interfere with a patient understanding and complying with the therapy. So that shared decision making, really knowing your patient, having them understand what your goals are and the decision you believe is best for them to move forward. And then to educate them on self-management and appropriate health care. Education programs could range from advice on exercise. I mean, if we don't optimize all these other aspects, you're not likely that moving to biologics is going to have as much an impact on their overall quality of life, including cognitive behavior elements, multidisciplinary rehab programs that include smoking cessation, education on diet, etc. Ongoing nurse support when patients have questions, because even if you have covered everything, which you probably haven't, they're going to have questions. They're not going to have recorded everything that you think you have gotten across. And so to have resources for them to continue to lean on, and then to really write things down sometimes and optimize their care plans. So what does a success look like? In COPD, in general, chronic use of oral corticosteroids is discouraged and less common than it is with difficult to treat asthma, but that in those patients that are on oral corticosteroids often will want to try and reduce or eliminate that. Improving activities of daily living, improving their quality of life. Improvement in lung function, again, more common with asthma, but in the best therapies in COPD, we often do actually have improvement in lung function. And then a common shared goal in both asthma and COPD is reducing flare-ups and exacerbations and bad days. And so when we can do that, really any of these are a success. But when we can do all, then I think really the patient completely buys into how we're impacting their lives. Okay, so the following animation covers potential barriers that patients and providers may encounter with biologic therapy and suggestions for how to overcome these treatment challenges. So we're going to move forward with the animation video.
Experience with the use of biologics to treat asthma and COPD has revealed a number of barriers that may be associated with the integration of this relatively new therapeutic approach into existing treatment regimens. Some of these barriers are related to risks and safety of the biologics. Overall, the adverse effects associated with biologics are rather rare, the most common being injection site reactions. Other rare adverse effects include hypersensitivity reactions, eosinophilic complications, conjunctivitis, and/or keratinitis, GI-related adverse events such as diarrhea and gastritis, musculoskeletal effects such as back pain and myalgia, immunogenicity, and infections. Patient-level barriers to treatment may include nervousness and/or fear of biologics, similar to vaccine hesitancy, reluctance to add a new therapy to complex treatment regimens, variable and/or delayed onset of efficacy, regular infusion requiring patient training, and economic barriers that include cost and insurance issues, such as need for prior authorizations and high copays. A number of options exist for mitigating barriers to inclusion of biologics in patient treatment regimens, depending on the source of the barrier. For many barriers, patient education is the key to overcoming hesitancy. Essential education includes describe in plain language what biologics are and how they differ from conventional medications. Explain the potential benefits of biologics for reducing exacerbations and improving quality of life. Describe possible side effects and how to manage them, including anaphylaxis action plans and prescriptions for epinephrine autoinjectors if indicated. Inform patients that the adverse event risks are similar for biologics and placebo in both asthma and COPD, as shown in recent meta-analyses. In addition, teach proper injection technique for self-administered biologics and advise patients to avoid live vaccines during treatment. Mitigation is also available for economic barriers and access issues. For patients with no insurance, the website healthcare.gov has detailed information about how to get healthcare coverage they can afford. For help with prescription costs, several options are available, including the American Lung Association and the patient assistance programs offered by product manufacturers.
So great, Stephanie, I really did enjoy your presentation, but it strikes me just how far we've come with asthma, and we have really elaborate, precise algorithms with, boy, almost a half dozen therapies at this point. And COPD, given the much greater experience in clinical trial data with asthma, wondering as the clinical trials come in with COPD, will the algorithms for treatment with the various biologics be similar, or are the diseases different enough that we may require very different strategies in our approaches with COPD patients?
Yeah, no, I think that's a really good question and kind of gets at the one of the major points, like, well, what do we do for our patients where this, what we have a pretty small group of patients that we're treating currently. And I'm certainly hopeful that as we see more clinical trials read out, that we're going to have more options potentially for inflammation beyond type 2, just beyond just the type 2 pathway, so that we might be able to treat a broader swath of patients, and that maybe we'll even be able to treat patients for symptom control or for the other things that bother, are particularly important to a patient. So I certainly am interested to see, are we going to have multiple kind of, are we going to have something similar for our COPD patients, where I can say, hey, well, if you have blood eosinophils of this level or another biomarker of this level, that you may be eligible for this drug to help you with either exacerbations or symptoms. And if you have blood eosinophils of this level, then maybe this drug will be a better choice for you. So I'm certainly hopeful that we will get there. What do you think?
I think COPD is a disease that you need to set your expectations a little bit better. In asthma, especially in more moderate asthma, we actually hope to nearly completely eliminate those bad days and the variability, and in the best of situations, completely eliminate symptoms. Whereas in COPD, you're almost never going to eliminate the chronic aspects of dyspnea and some aspects of the clinical symptoms. And so if you set expectations, we can have really an enormous impact in this population. But I think it's different expectations. There's a lot of controversy as to whether high eosinophils in COPD is the same mechanism as in asthma, and we're increasingly believing that they may actually be very different endotypes, and maybe even different cell types of eosinophil subtypes. So I think we have a lot to learn to be able to answer that question I gave to you, and I thought you did a pretty good job of really answering what I think is probably an area where we need to learn a lot more.
Right. I think we're all very hopeful, but I totally agree with all your points, that especially in regards to level setting. Have you kind of thought about, like, what do you do with your patients as far as kind of that level setting? Like, what are you expecting to see, and kind of what is your hope for what these biologics will do?
Yeah, I think we have to set expectations. I mean, just as when you give an antihypertensive, you're looking to reduce long-term downstream events, that drug may not get you to feel better at the moment. And so education and understanding really then becomes critical, so patients understand we may reduce bad days, we may reduce that variability, we may reduce those flare-ups and even the hospitalizations, but we're not going to get you on day one, running around the lake with your grandchildren. And so that's the part of doctoring, as I had mentioned, that um, really is not what's in the textbook sometimes, but sometimes the most important thing to getting your patients to understand and comply with their therapies.
Yeah, I think that's a really great point that we really just have to, you know, and realizing that some of those comorbidities are also really playing a role, or that we have deconditioning that's been building up over years. And maybe as you start to feel better, you need to be doing those things like pulmonary rehab, or at least exercising more and trying to kind of build up some of that endurance, because those things are going to be, all kind of wrapped up together. And that's one of the reasons it's so important to treat your comorbidities and make sure that all your other issues are taken care of to the best of your ability, because they are very much wrapped up into how you are feeling, especially for a COPD patient.
So we've been talking about phenotypic variation and differences in endotypes for a long, long time in the hope of treatable traits. And I think with the emergence finally of an approved biologic in Th2 modulation, and then hopefully migrating even to more specific Th1, Th17 neutrophil type biomarkers, that we can really target that individual patient in front of us and give the very best therapy for that patient at the right time.
Yeah, yeah, absolutely. That's a good point to end it on. Thank you, Dr. Skirpa.
Thank you, Dr. Christensen. I appreciate sharing the time with you.